Hi, I'm Amy Blodgett, and I'm completing the Master of Science in Nursing program at Pacific Lutheran University. My clinical capstone poster was on miscarriage education for nurses in the emergency department. This project came about through my clinical placement at Virginia Mason. It's actually a joint venture project between Virginia Mason and CHI Franciscan, who are teaming up to bring obstetrical services to Virginia Mason Hospital in downtown Seattle. My preceptors were Karen Park and Tiffany Knopf, two nurses that have extensive experience in family birth centers. Both have worked within CHI Franciscan and bring decades of experience to the team. So my preceptors asked me to design a perinatal bereavement program hospital-wide because this wasn't something that the hospital currently had. They anticipated quite a few training needs throughout the hospital. So the focus of my poster, though it wasn't the extent of my project, was focusing on miscarriage education for nurses in the emergency department. I focused on this because the needs assessment that I completed really revealed that nurses in the ED were really nervous about the addition of a family birth center to their unit. They have treated first trimester miscarriage occasionally because that's something that shows up in any emergency department, but they really anticipated that adding a birth center would increase the number of families being cared for in the ED with a miscarriage. So where I started out with this was with a literature review, and I found some pretty striking information. The first being that 1 in 5 pregnancies ends in miscarriage. So this is an incredibly common experience for families, and that most patients are treated in the emergency department for a miscarriage. Actually, almost 60% of families only receive treatment in the emergency department and have no follow-up care afterwards after they're discharged home. So women who miscarry are at increased risk for post-traumatic stress disorder, anxiety, depression, and these symptoms can really persist for up to 2 years. So what the literature review showed me was that women are generally dissatisfied with the care they receive in the emergency department. They feel like there's a lack of sensitivity, a lack of support, that they really don't get the education that they need when many of them are discharged home and have a miscarriage completed at home. Women are pretty surprised by the amount of pain that they experience, and this can be further traumatizing in addition to losing the pregnancy. My literature review also found that nurses experience a high level of distress when caring for families losing a baby, which makes sense. It was not surprising to me. But really, I wanted to look at how that distress we experience prevents us from engaging with these families in a way that they need. So that was kind of how this project came about, to try to figure out whether increasing training for emergency room nurses when they have no training in miscarriage support would really allow them to feel more comfortable and more confident to provide patient care that ultimately was better for our patients. So the methods I used, I started with a needs assessment, really looking at what existed already, where are the gaps in training, and where can we create system-wide change that helps support nurses to provide care to these families. I went through the review and approval board through Virginia Mason. The institutional review board approved this quality improvement project. And the two main areas that I focused on were creation of policy and miscarriage education directly for staff. It was important to note that this is a multidisciplinary team. The meetings that I was in weekly included every department within the hospital. And it really took an integrated approach in order to provide all the services that families need. So the policy updates, the main points that I want to highlight were that we prioritize these patients in triage, that we get social work involved with these families, and that we have case management follow-up to ensure that if they didn't get the education and the support and resources they needed, that they get them outpatient. The miscarriage education that I provided, the original plan was to become a trainer through Resolve Through Sharing, which is an evidence-based national bereavement program. And then the plan was for me to train staff directly. That unfortunately didn't happen because of the COVID-19 pandemic. All of the Resolve Through Sharing training programs this spring and summer were canceled. And so I had to improvise a little bit and created my own mini curriculum. You know, I wasn't able to, in a few months, develop the same sort of robust training, but the plan is eventually to bring that to the hospital still. So the evaluation methods I used were the end-of-life professional caregiver survey from the Yale School of Nursing. It was a 5-point Likert scale and measured pre and post surveys for nurses in how comfortable and confident they felt in providing miscarriage care to families. The results were anticipated. These are not actual results because we were not able to implement the intervention. But the expected outcome were that nurses felt more comfortable, felt more confident, and that they engaged with their patients in a way that helped support families in their grief after a miscarriage. So I think that some of the surprises that I found in implementing this program were that the training needs for the emergency department are really different than what I'm used to. What I'm used to is a 4-hour or an 8-hour training day where everybody comes to an in-service and is able to sit down and really get into the nitty-gritty of a topic. And in the emergency department, it was more effective, and the nurse manager requested that I give little tidbits of information over 5 to 10 minutes at their daily huddle, which is what I did. So those training needs are really different because it's a different environment than where I work, which is in labor and delivery. I think what it reinforced for me was that there was consensus and there was good feedback from the nurses that yes, they are really nervous and uncomfortable in these situations, and that it is distressing to them, and also that they always want to provide the best care. So they're kind of stuck in this position of not having the training or often the time, given the fast-paced nature of the emergency department, but that with training and with support and with policy that helps them provide that care, that they absolutely will do it. I think the takeaways that I would like anyone to have are that staff support is a critical issue in all areas of nursing, but especially in bereavement. We need to be able to support our colleagues, understand the emotional impact it has on us, and help recognize how that presents a barrier to care. Though families are grieving and suffering in a way we can't imagine, we can unintentionally add to that grief by not providing care because we're uncomfortable, because we're emotionally invested as well. So I would like to thank Karen and Tiffany for all of their support, for their trust in me to create a program that was going to work at Virginia Mason, and for all the knowledge that they offered. Thank you.